you all so much for coming, and I'm really looking forward to telling you about something that I feel really excited and inspired by, and look forward to answering questions. I'm going to cover a lot of information. I'm trying to hit a lot of highlights so we can have some time for discussion at the end. And really, I think this is one of the key pieces in the title, the power of working together for perinatal quality collaboratives. I want to begin by thanking Anne and George. I had a chance to meet with them last night, and I just really appreciate not only their Southern hospitality, but their vision and leadership in trying to improve care and outcomes for children and families in Alabama. So thank you so much for making my visit possible. I'm very grateful. I'm standing here before you, but OPQC is the work of many, and you'll hear me talk about how we've tried to develop a foundation and infrastructure that's across Ohio. Martha already pointed out Susan and Jay. There are many other people that could be standing here doing this presentation, so we're very lucky that we have a community that works together with a shared vision, and I'll talk more about that. Does anybody know what this is? Cicada. Do you have cicadas in Alabama? Yeah, okay. I grew up in the Midwest, you can probably tell, and we had cicadas every 17 years. And about 10 years ago, in one of the Institute of Medicine reports, one of the people wrote that it takes about 17 years for guidelines to get into practice. And they gave the example of beta blockers after myocardial infarction. And it took 17 years for those to be widespread. I expect with social media that has speeded up to some extent, but I think one of the things that I struggled with when I first came out of residency and training was just the amount of information and how did I know what to do and how could I be giving the best care all the time. And I think that's been a lot of what's driven me in my work. So one of the thoughts that I had is how do we speed up these 17 years? How do we get what we know into what we do every day? On the left side, David Davis wrote 3 different articles in JAMA, 95, 99, and 2002. And he was really trying to talk about what is effective continuing medical education. And I'm summarizing some very scholarly work into 3 bullet points. You need to have a needs assessment. What are the gaps? What data do you have that tells you what you need to work on? To be effective with continuing medical education, it needs to be longitudinal and interactive. And you need enabling or supporting tools. One of my colleagues and I, who were working then at UNC, which is how I became a Tar Heel basketball fan, we really thought a lot about this and the role of what's the responsibility of an academic center in doing CME that's effective. And we realized it had to be more than guidelines. At about the same time that Davis was doing some of this groundbreaking work on continuing medical education, the Institute for Healthcare Improvement, IHI, developed something called the Breakthrough Series model. And it really had very many of the same principles. It was you needed data. It was a longitudinal interactive effort that took place over 9 to 18 months. And you gave people resources and built a community to drive change. And I'll just say that both of these efforts, and many publications on both, are really a foundation for much of the work that we do. As I mentioned, we live in a network world now. So when we started work on the Ohio Perinatal Quality Collaborative, social media, the internet was being used, but in a much less robust way than it is now. So we are actually accelerating the pace at which change and connection happens, and I think we can build on that. So when I talk about the power of working together, that's really how the world is going to be. And so I think that's what the many successful networks are telling us. One thing I don't know if people know the story about Microsoft and CARTA and Wikipedia. Microsoft wanted to develop an online encyclopedia. It paid experts to do it. And I think after the first year or two, they only had maybe 10 or so of these content pieces up. Wikipedia, which used volunteers and a process for screening and doing things. You know, I've been on Wikipedia multiple times this week, and I suspect you have as well. So I think we have to think in different ways as we think about networking and collaboration, and that's what we've been trying to do with some of our work. One thing that I do at Cincinnati Children's, where I work, is I'm the senior faculty lead for the Learning Networks program. And I want to briefly tell you about that before I turn all my focus onto perinatal quality collaboratives. Learning networks, based on an Institute of Medicine model, are collaborative, multi-site communities of patients, families, clinicians, and scientists who use data for clinical care, improvement, discovery, and innovation. And this was actually something that the IOM wrote about 10 or 11 years ago. And it's really been the ideal that we try to strive for. I think in the future, data that's in the clinical electronic health record can be used in these ways. Some of the networks are making strides in that. But I think one of the things we want to do is think about how do things with quality improvement, research, and innovation really merge so that we're really moving all those things forward. And I'll show you some examples that I think demonstrate that ideal. At the Anderson Center at Cincinnati Children's, where I work, we currently support 8 learning networks. I'm going to tell you about some of them. They range from autism to the Cystic Fibrosis Foundation work, OPQC. We just last month launched 4 new networks with PCORI funding across pediatric rheumatology, nephrology, epilepsy, and autism. We started in 2006 with the Inflammatory Bowel Disease Network, Improve Care Now, with about 6 or 7 centers. We now support 8 networks with a total of 516 teams at 289 sites, 43 states and DC, and 5 different countries. So a lot of what I'll be talking about is really built on what we've learned. When we started out, we knew some. We've learned a lot. We've made mistakes. And so as I share some of our work with you, it's so you can go faster and farther sooner. I'm going to give you some really brief examples of some of these networks. Improve Care Now was the earliest network. It started with 6 sites, and it's focused on pediatric inflammatory bowel disease. Mitch Cohen, who's chair of peds here, a gastroenterologist, was a big proponent of, and it's one of the reasons this got started. He received funding from the American Board of Pediatrics back in 2006 to fund this, so thank you, Mitch. When this started and when they brought on teams, the remission rate across pediatric inflammatory bowel disease was at about 55%, that green arrow on the side. Last year, without any new drugs, but with standardizing protocols, being more reliable in how care is delivered, the remission rate across that disease, a common rare disease in pediatrics, is at 81% remission. So really terrific work. And they've gone from 6 centers to 106. More than 30,000 patients are in their data registry. almost 1,000 physicians, and they estimate that included in the registry are more than 60% of all patients with inflammatory bowel disease in the US. Another network is a cardiology network, which focuses on infants with very complex congenital heart disease, hypoplastic left heart or half a heart. When I was in training, those babies died. They now go through 3 open heart surgeries, and when we started this work, we focused on the period between the first 2 open heart surgeries. What we've been able to do is decrease mortality between those 2 surgeries by 40%, which was very exciting. We've partnered with patients and families, well, parents in this, and a quote from one of the moms who said, "We can learn from one another and get better faster." Again, I think one of the mantras that we often think about. The last non-PQC that I'm going to talk about is the Solutions for Patient Safety Network. It has more than 100 children's hospitals across the US and Canada. They estimate that it includes, data is there from more than 50% of all children hospitalized in the US. And they've been able to show across 11 different hospital-acquired conditions improvements in care. They estimate that in this time they've saved more than 9,000 children from harm and saved almost $150 million from averting different problems. So one of the other networks, and what I'm going to spend the majority of time on now, is the Ohio Perinatal Quality Collaborative. And our mission is through the collaborative use of improvement science to reduce preterm births and improve maternal and birth outcomes across Ohio as quickly as possible. We work very closely and are funded by the Ohio Department of Health, the Ohio Department of Medicaid, and there's some matching federal money that comes in through the MedTap program. I'm going to talk about Ohio, but I think that Alabama is well positioned to succeed in developing a perinatal quality collaborative. Of the networks that I talked about, the 8 that are going on at that have some infrastructure support from the center where I work, the Alabama Children's Hospital is in 5 of those networks. So you have individuals here who already know how this work happens, who are good at QI, and I think can be sparks for you in how that's happening. You already have, I met many committed people last night. You have people who are thinking about how do we pull together evidence and how do we get this into practice. So what I want to do is talk a bit about how we did it in Ohio and then have you think about how this might work for here in Alabama. One of the other things that I think will be very helpful as Alabama thinks about getting this started is Martha mentioned that the CDC is starting something called the National Network of Perinatal Quality Collaboratives. If you put that into Google, it will come up with a toolkit that many of us helped develop and will show you just some great key issues about that. So there are people that are ready to help and support how this work is doing. By the way, the blue means where there are QI efforts going on in perinatal in an organized statewide way. I think the yellow was those who were developing and working on it, and the brown were those that hadn't been quite there yet. So there really is a national movement to do this. And Ohio was selected and invited by the CDC to be a mentor state for others. So I'm going to now focus on OPQC. This shows you all the work we've done. This is our portfolio of work, and let me explain how these are. We started, the state of Ohio got an early grant in 2008 from CMS. So we started working on bloodstream infections in neonatal work and 39-week scheduled deliveries, their early elective delivery project in OB. In the gray areas, those are ones that we've sort of put into sustain mode or closed out. And these are our active projects here. What I want to say, and I want to sort of brag a little bit, and that's what I'm going to do in some of this, but the key point is we didn't start out with this portfolio. We built up to it over 10 years, and we've built up staff, we've built up infrastructure and data. So the important thing is to focus, start with something. One of our mentors always says, start before you're ready, and get going. And then over time, you can build out something that is broader and reaches everyone. So how did we begin this in 2008? One of the things we did, Jay, the person who was our administrative or project director, the neonatology lead, and me, divided up the state, and we actually made a road trip. It's been really important for us, a little different in Ohio than in Alabama, where we have 6 children's hospitals. We have 3 big cities, Cincinnati, Columbus, and Cleveland. We have many smaller communities, but it was important that this not be seen as something from the big centers, the 3 Cs as they're called, but that it was really enveloping of everyone. And so we actually divided up in different groups and went out and talked about what our vision was. I think it's going to be much easier as you think about doing that, because there are many examples now, and there's the NNPQC, the national network. So there are many good examples of how this model has been adapted in different states. But we actually went and talked to people and said, we want to share our vision of collaboration across Ohio, and we want to invite you to join us. We can't do this on our own, it won't be successful. And also asked, what matters to you? So it was really trying to build community, meeting with neonatal and obstetric colleagues out in multiple communities throughout the state. And we used a slightly bigger car than that to get around. But I think the point here I want to make is we have really endeavored to not have the leadership be from one center, to have it be a joint leadership, and then to have a group of faculty that are from across the state. And that's really been very, very important for us. So something that you all may want to think about. What are some of the key components that you need as you set up a perinatal quality collaborative? And a lot of this is on the CDC website. I'm just going to give you a few highlights. You need data. You can use registry data, population sources like the birth registry. In Ohio, we've been very fortunate that people who came before me had worked with the State Department of Health. We're able to give monthly data feedback on different outcomes to the hospitals, and it really helps drive some of the work that we're doing. They get their individual hospital data, and then we share aggregate data. So it's a helpful way to see how things are changing. So the availability of reliable and shared data at frequent and regular intervals is totally key to doing improvement work. We try to use a small amount of data. Often it's hand collected. We may start out with that happening at some of the bigger sites who have a little more infrastructure, and then as we spread, we try to think of how to make that easier, and we can talk more about that. Using quality improvement methods, shared goals. It's really important to have a goal that you're striving for. As I mentioned, we use regular performance feedback, and there's an idea of testing changes to standardize care. I will say that as a clinician, particularly with my internal medicine hat on, this idea of testing and maybe being wrong when you test trying to implement something was sort of hard for me to do because you don't want to get things wrong. So we try to create an environment where we say, why don't you try with one patient talking about X? Or with one clinical team, try this tool and see what you think. And if it doesn't work, then we've learned something. So it's really a different way of thinking than we think about in many of our other avenues of clinical care. And then I think it's using methods, some of the collaborative methods, to facilitate collaboration and sharing of knowledge. All teach, all learn, knowing that someone in a small community may have come up with a very innovative way to do things that can be very helpful. When we started the 39-week project for early elective deliveries, that was something that was new at the time. We happened to be a bit ahead of the curve looking at a statewide effort. And one of the individuals who'd been successful was an obstetrician who was African American from a small community hospital in Columbus, who got up at our first session and talked about what he'd done. Very humble guy. And so it's really, we can learn from other people out in the community about how they make change. We try to have face-to-face meetings. We have monthly calls, webinars, we have an email listserv, and sometimes the quality improvement consultant will actually go out and meet with the teams, or Jay has done that as well. And then you need some project management and administrative infrastructure support. We use something called the model for improvement, where you ask 3 questions. What are we trying to accomplish? How will we know if a change is an improvement? And what changes can we make that result in improvement? And we make these tests of change over time to try to really learn about what works, because you have the key concepts. A guideline tells you here's the sorts of things that need to happen, but how they work in each different clinical setting may vary a little bit. And so you test how it will work in your setting. I'm not going to go through all of this. This is a bit more wordy than I like to show, but I think this is what one of my colleagues, a neonatologist, put together, and all projects involve data collection, and she was trying to make some points. Data is an integral part of improving care. And this, and my slides will be available, but it talks a bit about how we test our way into learning what works in our site. Here's a picture that I wanted to share, and Jay often says this, so I'm quoting Jay. OPQC is not the police, and in all of our networks, we really lead by influence. We have no business relationship, no contracting relationship with any of the sites. You know, clinicians, nurses, and physicians go to work every day because they want to do the right thing for patients. So I think we're all trying to do the best for our patients, and we can learn how to do that together and from each other. It makes it more efficient. So we really develop a culture of contribution, again, where all teach, all learn. And it's, again, we're not the police. We can't give you a policy and say this is what you have to do. We can say here's what ACOG is thinking, here's how we think are some of the key principles, and let's try to work on this together. And we can probably talk about that afterwards. But I think this has been very, very helpful. The only contractual relationship we have are data use agreements. And we say this data cannot be used for marketing. You can't use this data for competition. We're using the data for learning. So very, very important comment. It takes a village. When we started, we didn't have all these groups on board, but we found so many people. We have a monthly call with our partners where the different groups talk about what they're doing and how they're working to improve care. When we think about starting, these are some of the design principles that we think about for our networks. We focus on the outcome. That's a little bit different than when you're doing a research project. And some of my mentors have just emphasized it's really a relentless focus on outcomes that's going to make the change. We build community. I've talked about going out to sites. We have face-to-face meetings when we're working on a project, typically every 6 months or 8 months or so. We have started to, that was our initial model, we're starting to do regional meetings because those might be easier for people. We used many types of science, both qualitative, system science, QI, and then it's really important trying to use data effectively and feasibly, getting just what you need without burdening people, and then using technology effectively. I talked about the aim, and again, I think this may be a little different than in research, but Yogi Berra said, if you don't know where you're going, you'll wind up somewhere else. So it's really important as a group, and that's one of the first questions in quality improvement is what's your aim? What are you trying to improve? And I'm going to go through somewhat quickly 3 of our signature projects to give you some examples of what we've done. I'm going to start with the Scheduled Birth Initiative, Early Elective Delivery, 39 weeks. Our aim was to decrease the number and rate of scheduled births between 37 and 39 weeks gestation that lacked documented medical indications. And I believe we said we were going to reduce this by 50%. I'm trying to remember what our first aim was, but I couldn't find that when I was putting these together. We started out, there are 108 maternity hospitals in Ohio. We started with the 20 largest that accounted for almost half of all births in Ohio and about 60% of Medicaid births in Ohio. We took the ACOG guideline and really thought about, there were some areas that were probably open to interpretation in that guideline, so we tried to frame what were we trying to do. Right before this had started, there was an article in Pediatrics that said about 3 to 5% of infants that were born between 37 and 39 weeks ended up being hospitalized in the NICU. And so that could be a real motivator for changing things. And we used some of that sort of data to get people on board. We used quality improvement methods. We asked these 20 sites to collect some data on each birth born between 37 and 39 weeks. Because they were the larger maternity hospitals and was a 1 page of data, we were able to have people agree to do that. We don't pay people to participate in this, but it's really a part of improving your care. And we use the state birth registry for our outcomes. So let me show you where we were and what happened here. So what you can see with that red line, and we use statistical process control to track our data. That red line up there that's between 16 and 17, this is from the Ohio Birth Registry. About 17% of births on average for a number of years were induced between 37 and 39 weeks without medical indication by the birth certificate. We know birth certificates aren't perfect, but we sure were holding steady on that number. We began in September 2008 with this project, and there was, a fairly quick turnaround to when you got started with this and when you'd begin to see data. So this is compressed, but but over about 6 to 8 months in these 20 hospitals, we started to see changes. What we then did was, as we got to that and began to see some improvements, we saw about a 60% improvement. Jay presented this, I think, at the February or March 2010 MFM meeting. And we then worked with a next group of 15 hospitals, because we said working with the large hospitals is one group. What happens when you start to go to the community? We worked with that group, refined what we call a change package. What are the key principles you need? It goes a bit beyond guidelines, like how might you implement this? How could you put this in practice where you are? And we learned a lot from those 15 hospitals. We used just the birth certificate as our feedback data, and then we went to the other 80 hospitals. And we did this in a stepped wedge design. So one thing I want to say is you can use networks for some terrific research when you're doing QI. And that article, I think, was just published about how we spread that out in 3 waves over an 8-month period. What you can see is that we're now down at about 5%, which is by the birth certificate about where we've thought we wanted to go. To make sure that we were seeing this data correctly, what we did, and this is also from birth certificate data, these are the 37 to 39 week births. This is where our efforts started. Those are full-term births. And as you can see, it's really very much a mirror image, so that as we started in 2008 and those births went down, full-term births went up. So that reassured us that what we were seeing was accurate and the transition was in the correct place. You can imagine that with shifting this number of births to term, Medicaid has been really pleased about that. It saved money for them. It saved, most importantly, it's better outcomes for babies and families. We've been able to, many of the people who participate are academics, and so we've been able to publish, and I'm going to show you just a few of our articles, but this is one of the early ones that was published. We worked mostly in hospital settings, and in 2013 our state partners said, you know, we're glad we did something around antenatal corticosteroids. We looked at breastfeeding for early preterm infants. And they said, all good stuff, but we want you to focus on what are our key issues in Ohio. And those are infant mortality and the opioid epidemic. From dinner table conversation and some things I looked at, I think we're all sadly on the same page on that one. And so that has pushed us to start thinking about how do we get out into the communities and into maternity care practices. And we're learning on that. One thing that may surprise you is that I think Ohio ranks in the lower third in the country for infant mortality. We often rank in the lower 2 or 3 for the discrepancy between Black and white, African American and white infant mortality. So we're just about at the bottom. I believe we're worse than Alabama for that. So you can see that infant mortality for Blacks was 15.2 and for whites 5.8. So really significant differences. So this is an urgent issue that we need to address. I'm not an obstetrician, but one of the projects that we started on was the progesterone project. It was one of the medical treatments that can impact prematurity. And it works for those women who've had a previous preterm birth or a short cervix, but we looked at both of those. So we began a project with funding from Medicaid. We said this should cross all all races and socioeconomic barriers, and we hope that using this and implementing this can make a difference. And we actually thought, well, people know the guidelines. We looked at a few sites and saw some things they had done to really facilitate the use of progesterone. And I am going to briefly show you some of the things that we did. We developed, this is one of the things we do for all our projects. It's a key driver diagram. We put all our theory on one page. And our goal was to decrease the rate of premature births. You start with your outcome. Here are the things that you think are the drivers, and these are the strategies. So we developed one of these. It's really on one page how we can explain what we're trying to do. And we saw those drivers in yellow as those things that we needed to do. Consistent and early recognition of prior preterm birth. How do you fast track someone who has a prior preterm birth? How do you expedite getting progesterone? And those were some key things that we needed to work on. We standardized protocols. We talked about how you did a quick screen for preterm birth, 3 questions when someone showed up or called in. We developed a log. We had someone at each practice, and these were larger practices being a navigator. And we found out that communication among Medicaid, the managed care plans, the county that kept someone on Medicaid were quite difficult. And so we started out thinking we were going to work at the practice level and just help practices do this better. What we found is, yes, that needed to happen, and we needed to work at the system level with Medicaid to really help women get this. So we found it was a coordination and collaboration across multiple sectors. Frontline staff, the Departments of Health and Medicaid, the managed care plans, Job and Family Services, and OPQC. This is something that our Medicaid medical director put together. She and Kiba and I presented at a meeting a few months ago, and this was her quality improvement system level about what she needed to do, and we worked very closely. Oh, people are getting dropped because this wasn't communicated, and we figured out how could we help to do that. So I think for this one, it was very much a practice and a system level effort. And where did that lead us? Well, we were pretty excited about this. This is a complicated slide, so I'm just going to highlight a bit what happened. This is, again, birth registry data. It's looking at the births before 32 weeks across the state. And again, the hospitals we worked with accounted for 60% of Medicaid births, where a lot of these preterm births were happening. We decreased births across the state before 32 weeks by 6.6%. When you looked at some subgroups of this, if we looked at those with a history of previous preterm birth, we decreased preterm births in that group by 17%. This looks at, this is women with all preterm births, and we decreased those by 20%. And I think what was really exciting to us, because of the incredible discrepancy between African American and white preterm births, in those moms who had a history of previous preterm birth, we decreased that rate by 20%. Small numbers overall, but very significant when you think about the impact that those births have on the child, the family, and on Medicaid spending. This was published last year and details much more of what we've done. What we do when we finish a project is develop what we call a change package. These are all online. We have one for this, for 39 weeks, for long-acting contraception. We just finished the LARC project we just finished. But this is specific to Ohio, but we think that it is very generalizable. So feel free to go on and look at this and use it. One of the things that also happened as a result of this project and the collaboration with Medicaid is there had been a pregnancy risk assessment form that was developed in the 1980s that we were able to work with them, work with those 20 practices and update so that now when a woman is seen, this gets filled out. There's actually a form so that progesterone can be prescribed. It goes to the managed care plan. It can go to home health. And so we're looking at this as something that will help us with data going forward for progesterone, for smoking, for other things. So this took probably 2.5 years to develop, but it's really exciting, and that was launched last year. Our future focus is moving out much more into some of the counties where there are the highest infant mortality in the state. So what does it take to succeed in some of these projects? A sense of urgency, which we had, infrastructure, data over time, trust in the partners and the QI process. Moving the needle on progesterone took us a long time. Unlike 39 weeks where the interval between what we were doing and the outcome was just a few months, this was we were getting women in at 16 weeks, 20 weeks, having to make changes and then follow the data way out. So it takes trust in the partners and in the process. To get there. So I'd say when you start, maybe start with an easier one because you don't always believe it's going to happen when you've got a long time. And then for some projects, it's going to take practice level change and system level change. I'm going to very briefly go through the work we're doing on neonatal abstinence syndrome and what's happened. Things came, I think, because of the highways early to Ohio. Sadly, I think Ohio has been on the forefront of working on this, and it's one of those things that a club you don't really want to be in. The governor gave money to the 6 children's hospitals in 2012 because they were seeing such an increase in NAS and asked for them to learn about it, understand the epidemiology, come up with a bundle, and identify areas of variation. They came up with a bundle. They found among those 6 hospitals significant variation in length of treatment, type of treatment, and length of stay, and really worked on decreasing the rate. And I took the slide out, so I don't remember exactly how much they dropped it, but it was significant. What they then said is, let's spread this to the other level 2 and level 3 NICUs in the state. And it went, we have 54 level 2 and 3 NICUs, so we had 52 of them participate. We had a key driver diagram, and one thing I want to point out is we focused on length of treatment and length of stay, the non-pharmacologic bundle and the pharmacologic bundle. But what was really important also was by increasing identification and compassionate withdrawal and really compassionate treatment of the mother and the baby and the family dyad was in our key driver diagram. We wanted to reduce length of stay by 20%. We recognized that that was a proxy. We've done some things to track attitudes among staff so that we can begin to shift how people think about these moms and babies. So what did we do? We developed and implemented standardized processes for identifying, evaluating, treating, and managing these infants at discharge. And then the second bullet is we created a culture of compassion, understanding, and healing for the dyad. We used materials. The Vermont-Oxford Network had developed a lot of work, so one of the other things you say in QI is to steal shamelessly and share seamlessly. So we just pulled in what other people were doing and began to pull materials together. Our results across these 52 NICUs were that after 9 months of work, we decreased by 9% the length of treatment from 13 and a half days to 12 days. And this is a marker for us. There were other things going on, but that told us that babies were being identified and treated in a more standard way. We decreased the length of stay as well by 9% from 18.3 to 17 days. We developed a guide for families. This is on our website. You're welcome to take it. You can adapt it, put your logo on it, just mention us somewhere on there. But we're really happy for you to use this. And it really goes through, this was developed as a guide for the family. We've worked hard to improve recognition and non-judgmental support for narcotic addicted women and infants. We're probably on version 3 or 4 of the manuscript and hope to submit it soon. But what we did was show that we actually were able, in surveying these NICUs that were participating over time, to make some significant changes in attitudes on this. And I think just last month our article was published about the work that we've done. One of the things that we learned after doing this and after going through is that there continued to be variation and uncertainty in the non-pharmacologic care, both in looking at breastfeeding for these infants and in the formula. There's some thought that hypothesis that higher calorie formula, because these babies are using a lot of energy, could be helpful in helping with the withdrawal syndrome. And there was also some thought about low lactose formula. So those were 2 things. What I want to say to the researchers in the audience is when you have a network and once you've stabilized your baseline, you can then test different strategies very nicely. And you've got a group that is amenable and interested in doing that. So we did something called orchestrated testing. And the question was, is there a certain formula that's best for those infants? We prefer breastfeeding, but that wasn't possible for non-breastfeeding infants. And you can see that sites pretty much self-selected into one of 4 groups of what they were using. There are some beautiful system engineering diagrams for this. I think this has been written up. I don't think it's been published yet. We submitted it. But what we found, here's cutting to the chase, is that there was a consistent benefit of 22 cal formula on weight loss, treatment failure, and length of stay. So what we saw was that those infants who got this, there was actually a decrease in infants receiving pharmacologic treatment when we did this. We were able to shift babies. And what we found in the network, something that happens is that there tends to be natural diffusion. When people know what's happened, they start to increase their uptake. And you can see that what was at, I think about 30% before has bumped up. And we've seen that in some of the other networks. Before publication comes out is when there's evidence, it disseminates fairly quickly. We also saw that there were further reductions in length of stay when we implemented this. So length of stay went from a total reduction then over the whole effort of 2 days, because it went from 17 down to 16.3 using the 22 cal formula. We sadly have a cohort of 6,800 infants who've been exposed to maternal narcotics, but we've been able to learn a lot from this and updated our recommendations. So I think one of the nice things too about networks, and Larry Green, who's very big in health behavior change. I happened to sit next to him on an airplane, total coincidence one time. And I asked, oh, what do you do? And he asked what I did. So he talked about, he says, what you're doing, he drew me a diagram that I have hanging up. He said, oh, so we try to translate research into practice, and what you're doing is showing once you do that practice then feeds back to research. So we've been able to update our recommendations. I'm not going to go through these now, both for the non-farm and the farm bundle, and have some general recommendations about how you want to treat these babies. Medicaid said, we love what you've done, this is great, but let's move upstream. Let's get to where we really need to be. So we're excited. After several months, we're about to launch a program with mentor sites, faculty who've done some, OB faculty who've done some very successful work in terms of working with pregnant women with opioid use disorder. And we really we need to build the capacity and capability of sites throughout Ohio to care for these women. And so we have 22 partner sites. We've sort of closed that at this point, although we're getting some in. People are really hungry for this. We want to develop a first change package because these 4 mentors are using somewhat different models, and that's okay. They're in different communities, different contexts. We're going to pull that together, work with them to work with the behavioral health providers and the MAT providers, medication assisted treatment providers, and really help develop, build capacity and capability in Ohio in the obstetric community to care for these women. Again, we have some materials that we'll be developing and using, and you can go to our website. You're welcome to use whatever. I'm going to end with saying there is the National Network of Perinatal Quality Collaboratives. I believe there's going to be, and we can ask Kiba about this, an annual meeting every year. It's only 2 hours to the east, so we hope that you all will be there. It's usually in November sometime. Right after Thanksgiving, so people are in a good mood when they come. Here's, in case you think, well, how could we do this? Here are the top challenges in a survey that Kiba did that other PQCs have reported. Funding, competing priorities, engaging physician providers, and et cetera. And there are a lot of people who've thought about this. We had these challenges, we have these challenges in Ohio, and as a community, we can work together and help each other with those. I had a great conversation, or I thought it was a great conversation this morning with many of the PEDS group. I think Jay was in the OB group, and these were actually some of the questions that came up. So, and there is a document there on the website. If you don't have this website, just put in Perinatal Quality Collaborative, CDC. This website comes up, and there's a guidance document with chapters on each of these pieces. I'm sure it'll leave you, it's like reading a good book, you'll want more, but it's a good thing to get started. I just wanted to end by saying this takes a village, and your village can start small and build. Ours certainly wasn't this big when we started. So I might just say, what's next, Alabama? I know enough about football here to say that I think there's some competition among teams, but I know this phrase that's called roll tide. So what are you all going to do to roll next, Alabama, to work on things? So that's my disclosure, and thank you very much. Sorry to go so fast over so much.